All right, hello. I'm Gary Kreps. I'm a local DC guy. I took the metro here today, and I'm glad to see you all. Baruch and Angie did a really good job setting me up. Hopefully I can compliment them and provide some details about what needs to be done. I'm a really big believer in the power of communication, and I think communication can be designed to address major health threats. But unfortunately, there's a lot of assumptions that limit the effectiveness of public health communication. One of the major assumptions is that communication is easy to do. And while it is easy to do, it's not easy to do very well. And I think that people try to come up with relatively simple, broad, encompassing, powerful, killer messages that they will develop to address major complicated health issues that sometimes work, sometimes don't, often make things worse. And in the area of infectious diseases where things are happening quickly and there's lots of problems and risks and issues, it's really important to try to communicate in ways that are most meaningful to the populations that need that information and provide them with information that they can use. Now, it's not easy to come up with strategies to do that, and I'm a very big believer in strategic, evidence-based risk communication. And so I'm going to talk to you a little bit today about some of the processes that I would encourage you and others to use to develop these kinds of strategic communication activities. Let's see if this can work. No, that didn't do it. This one didn't do it. That one did it. So what do we know about how well communication programs work? I think that what happens more often than not is that public health communicators have very good intentions. They really want to help people, but they have very limited data. And because of that, they don't always use the messages that really will reach the people they want to reach and influence them in the ways they want to influence them. So one of the things we need to do is kind of figure out what is it that you want to do, and what do we know about how well the programs that we've developed in the past and the programs we want to develop in the future will work. What influences do health communication programs have? How effective have you been at reaching different people? What has happened in the past that would encourage you to use similar or different strategies in the future? Is anybody paying attention? And a lot of the research shows that risk communication and public health communication in general often has extremely limited exposure, that this is not the primary place that people want to focus their attention, that they often will hear some little tidbits about the danger, but not a lot about the recommendation. How do diverse audiences respond to these programs? So one of the things that I want to talk to you about is segmenting your messages to specific at-risk populations. The idea of like one size fits all doesn't work very well with risk communication. That you need to figure out who do you want to communicate with, who are the people who are most misinformed, who are the people who are at greatest risk, where do they get their information, what do they need to know, what's going to work for them in their lives, in their communities, within their families, what can they do and what can't they do. Because once you know these things, then you can be very strategic about the ways that you communicate. What is being learned from the programs that you're putting out, and how are people responding to them? Are there any unintended influences? And unfortunately, research has shown in that many public health events, there are boomerang effects and unintended effects with different populations that actually make the problem worse, including unrealistic fears, people responding in angry and hostile ways, closing down bridal shops because they don't really understand the situation very well. And we really don't want to be a party to making things worse. We're part of the solution. Why do some of the health communication programs appear to work, and what parts work best? So this is really a kind of an unpacking. And also a recommendation that I'm going to build on a little bit later on is that we need to come up with very targeted, specialized communication programs for different issues and problems and for different audiences. One size fits all does not work. So what you want to do is become thoughtful about what do you want to accomplish, how do you want to accomplish it, and what do you want to do with different groups. And how do the messages that you create, how are they likely to influence different populations? Do we know what communication programs are intended to do? And I'm amazed when I do a lot of evaluation after the fact when a risk communication doesn't work well. And I ask people, what was it that you wanted to accomplish with this program? And they can usually only tell me in very vague terms. And it seems to me that if you want to do an intervention to improve public health, you need to be very specific about what is it do you want people to do? What are the issues that are at risk for them? What are the recommendations that you have? And you don't want to be very general about this. You want to be very specific and encouraging and reinforcing. Which audiences do we want to reach and influence? As I've talked about before, you don't want to try to hit everybody. You want to hit the people who are at greatest risk, the people who can have the greatest opportunity to stop the problem, to keep the infection from spreading, to make a difference in their homes and their communities. What do you want these audiences to do, and can they do it? Do they have the resources? Do they have the knowledge? Do they have the ability? Are you providing reinforcement for them? I'm a really big believer in the ecological approach, that if you need to provide the support within the environment to enable people to accomplish their goals, just telling them to do things is not enough. You know the old saying that people in tobacco control tell people say, quitting smoking is easy. I've done it 1,000 times. Okay? Well, what is the implication of that? You know, we can tell people they want to quit, but we're not really recognizing how difficult it is for them, and we're not providing them with the support, encouragement, and reinforcement that they need. So we need to figure out what do they need to do to accomplish what we want them to accomplish. Do we have measurable goals and outcomes in mind? So, I mean, I really shouldn't be giving this recommendation because this is a big part of my consulting business. I go in and I provide that evaluation for people, but it really makes sense that if you're going to be designing programs and you're going to be designing them on a regular basis, and infectious diseases are not going away, I wish they would, but this is kind of an ongoing process for public health departments, the CDC, the World Health Organization, many other organizations. It seems to me that you want to have a really clear set of what your goals, objectives are, and you want to provide some kind of measures, especially to have some baseline data. It's amazing to me how often I come in after the fact and there's no baseline data. What were people doing before? What did they know before? How do you know if you've moved the needle in any way with the communication that you've built? Is there an established baseline, which is what I just said before? Is there a strategy for making the programs effective? And this is a kind of a theory notion. There are a lot of really powerful social and behavioral theories that guide the way people are influenced, the way they perceive information, the way they interpret information, what makes them want to do things, what makes them recognize and respect and believe sources of information. What kinds of information are most interesting to them? What are the best ways of reinforcing behavior over time? Are we using any of those theories and models to guide what we're doing? And more often than not, we're not. It's back to that notion that communication is easy to do. There's a rush to judgment. Let's get it out. Let's do it. You know, let's spend the dollars when we have them. And there's not really a great opportunity to think this through in a very cogent way. Are programs sensitive to the unique audiences, including their cultures, needs, literacy levels, and expectations? So these are some of the basic factors that I'm going to be recommending that we begin to study and we know about ahead of time. You know, it's very hard to do this on the fly when there's an emergency, but you can do a lot of planning ahead of time and analyzing of different at-risk populations. What are their needs? What are their information needs? What are their goals? What are their orientations? What are their barriers and impediments? What channels do they like to use? Who do they respect? What do they want to accomplish? How do they frame these issues? These are really critical pieces of information in becoming strategic communicators. So many programs are based on good intentions but limited data due to the conception. If you build it, they will come. So this is a real notion. Let's just do it. Let's just, put it up on a website. People will come and get it. I've done a lot of work with federal agencies. They really are big believers in the power of the website. But then we go out and we study information. We find out that most members of the public who need that information never go to that website. And when they do, they don't understand what the information that's there. And so that's not really helping them. So building it without really being critical about who you're building it for and how you're designing it is not really a good idea. Rush to action. Let's just do it. Let's get it done. This is the way we've always done it around here. I'm still working. I've still got a job. Why should I change the way things are done? Well, because it hasn't worked very well. And people are not necessarily responding and listening to the way you do it. And there's a ton of case studies about failed risk communication efforts that we should be learning from. I like a program. It works for me. Well, the notion here is that the people who are designing the programs are designing it with their own frame of reference that makes sense to them. They understand the information, they understand the risk, they're compelled to do it, but typically the people who are designing the programs are not the ones that you're trying to reach. And they're not the ones that are at risk. And they're not dealing with all the different issues. So they're not the best barometer of what works and what doesn't work. So we need to be going out and focusing on who are the people you want to reach and what are their issues. Evaluation research is not in our budget. You have no idea how many times I've heard that. We have just enough budget to pay for the media, so we're not going to do this damn evaluation. I don't know how to do it anyhow. I don't like the damn numbers. Let's just do it and we'll get it done. And if it doesn't work, we'll change it later. In the meantime, that curve that was put up earlier by Mr. Rainford is getting worse and worse. And so, we need to figure out good ways of dealing with this early. And coming up with strategies of following up. Maybe if we need to refine the messages, we can do that. It's not a one-shot deal. Communication is a process, and there should be a number of opportunities to provide information and refine your message over time. Doesn't mean you should wait until you've got all the information, but you need to kind of give your best effort as soon as you can and then improve it and build upon it and reinforce it over time. Data gathering is too time-consuming. I'm not really trained to do this. That's not my job. I'm not a researcher. I'm a public health communicator. It's a very frustrating thing to hear. Data are difficult to translate and implement. I don't like those numbers. It doesn't make sense to me. And research is a waste of time and money. Boy, that hurts me. It goes right to my heart, I hear that. It's, oh, my God, because I think that research and data are your best friend. This is giving you rationale and direction for what you're doing. It's telling you when you make a mistake so you can fix it quick. The worst thing I've seen is when people do bad messages that don't work well, but stick by them. We've already paid for the advertising budget. We're just going to keep doing it, over and over and over again. So the need for evaluation research, I think, is critical. Good data are like turning on the lights. I can see now. And when you're dealing with a crisis, you want to see where you're going and why you're going there. It's difficult to get it right the first time, so good data allow you to adjust, refine, improve over time. So this is an ongoing process. Don't expect to get it right exactly the first time. Different strokes for different folks mean that you need to come up with different strategies for different audiences, and you need to learn about those audiences. Data gathering can help connect you to key audiences. So a lot of the work I do is a community-based participatory approach where I work with the audiences. I've learned the hard way that I don't know it all, and that I'm usually the dumbest person about a community that I don't belong to. And so early in my career, I thought I was the expert. I thought I knew all the answers. I had the degrees, I had the training. I was going to tell people what to do. And guess what? They didn't want to do it. And it didn't work very well. And so I learned to work with them and find out what's going on for them and use them as my partners, both to gather data, to refine the messages, and to implement them. Data can tell us whether the outcomes achieved were worth the investment. I see my red light is on. Is it okay if I continue to talk? 1 minute? Okay. Good data can justify major investments. So formative evaluation, I think, is critical. Really good needs analysis and audience analysis should be guiding what we're doing. We need to identify who the key audiences are and stratify them by homogeneous groups so we can come up with messages that make sense to those different audiences. We need to figure out who they are, where they're from, what they think, how they communicate, what channels they use, what are their literacy levels. We need to figure out what are the best strategies for communicating with these populations. Process evaluation is what we do while the campaign is going on. Once you come up with the messages, you're not done. Okay? You still need to do a lot of work. You need to evaluate how are people responding to your messages. Do they understand them? Are they paying attention to them? Are they influenced for them? Are they doing what you want them to do? Are they doing something else? You need to figure that out, and process data will allow you to track those messages and figure out what's going on. You need to test message, channel, strategies, and program usability. Do people use, like we are big believers in digital communication, but do the audiences you want to reach, do they have access? During an emergency, do they have, is the internet up? Are we providing information that they can use? We need to have ways of building into the system, ways to get feedback. I'm a really big believer in feedback. We need to get people to tell us what their experience is, what they want, what they like, what they don't like, and then use those data to refine our messages over time. We need to track responses to refined programs and figure out what works so then we can implement and sustain those good parts of the programs. So then the last part is summative evaluation. So all the data that you gathered during your formative and your process evaluation become really good baseline data for tracking changes over time. What have you accomplished? What's been working? What are the patterns of access? What are the patterns of program use? What is the level of satisfaction of users? What are the level of message exposure and retention? Do they understand? Are they remembering it? Are they using it? What kind of changes in behavior are going on? Is it move the needle in terms of infection control? Is there an economic analysis of what you're doing cost effective? Is it reducing incidence? Is it reducing morbidity? Is it reducing hospital stays? Is it increasing ability for people to act on their own behalf and to become more self-sustaining? What are the best program features and strategies so that we can build them in and amplify them over time and expand them for use in other programs? And what are the strategies for sustaining best practices? And I go back to the community-based participation because the members of the communities are usually the best ones for implementing and sustaining these programs over time. And then build support from the funders for institutionalizing based on your data. Data are your strongest friend for institutionalizing programs. If you've got evidence that this works and it saves money and it saves lives, that's great evidence. I'm not going to go anymore because I'm out of time at this point. I think you've got enough from me. Thank you all very much.